Hi, thank you, Julie, and welcome to everybody. We are so glad that you're here and able to attend our first of two fireside chats on awareness and preparedness for children and youth with special healthcare needs and children with medical complexity. My name is Bridget Glines. I am part of the Pediatric Pandemic Network. I'm the hub manager for UCSF Benioff Children's Hospitals in Oakland and San Francisco. And I also get to co-lead the disaster management domain, the weather task force, and the children and youth with special healthcare needs and children with medical complexity task force. And for the ease of saying that, I am going to, for the rest of this presentation, call that the C2TF. All right. We got some acknowledgments and disclaimers. The PPN is supported in part by HRSA. We're 0% financed with non-governmental sources. I'm turning off my video because my internet's unstable. The content presented here is that of the authors and does not necessarily represent the official views of nor an endorsement of HRSA, HHS, or the US government. We've got some learner notification for you. We have no financial or other disclosures to tell you. CE is available, and we'll tell you a little bit more about how you can claim CE near the end of the presentation. Three objectives for our fireside chat today. Talking about why children and youth with special health care needs and children with medical complexity need to be considered in disaster planning, describing three different perspectives for these populations and how a disaster could impact each group, and then identifying differences in planning for everyday emergencies for children and youth with special health care needs and children with medical complexity families and disaster planning for them. Our agenda. We had three phenomenal speakers lined up for everyone today. We had Dr. Stade had an unexpected appointment, so he will not be presenting today. Dr. Pulcini will cover for him. And I'm super proud to share with you, Dr. Pulcini is a pediatric emergency physician at the University of Vermont Medical Center and UVM Children's Hospital. And he's an assistant professor of emergency medicine and pediatrics at the University of Vermont Larner College of Medicine. He's one of our phenomenal co-chairs for the PPN C2TF. Dr. Stade is an emergency medicine physician at SSM Cardinal Glennon Children's Hospital in St. Louis. He's the pediatric site supervisor and chief of staff at SSM St. Joseph Hospital Lake in St. Louis. He's the PI for the PPN hub site at Cardinal Glennon and the other co-chair for our phenomenal C2TF. Dr. Stade is the co-chair for the PPN's pre-hospital domain. He's the physician lead for the Missouri EMSC Pediatric Facility Recognition Program and has been the medical lead for Cardinal Glennon Hub EIIC Pediatric Readiness Collaborative and the EIIC Pediatric Readiness Quality Initiative. And last but absolutely not least, Don Bailey. Dawn serves as a subject matter expert for the PPN and is a core member of the C2TF leadership team. Further, she's a consultant for Arizona Title V and president of the board of directors for AMCHIP, which is the Association of Maternal and Child Health Programs. Most importantly, though, Dawn is a mother to a daughter born with complex medical, cognitive, and physical disabilities. She knows firsthand how challenging it can be to navigate multiple systems of care and has the unique privilege to use her everyday experiencing in a consulting subject matter expert role to help improve our systems and services for the children and youth with special health care needs and children with medical complexity populations. And with that, I will turn it over to Dr. Pulcini.
Hi everyone. Thanks so much, Bridget, and thanks for everyone who's joining. Already taking a gander at the list of attendees. I'm impressed on who is here, and many of you are experts and advocates in this area. So thank you very much for joining us. And this is a fireside chat, I would remind you, and I'm very interruptible. So if you would like to interrupt or add anything, or frankly correct me, then you are more than welcome in which to do so as we sort of plug along. I am going to cover Dr. Stade's slides today, but what we thought we'd start with is a broad overview of children and youth with special healthcare needs from like a global level in terms of defining the populations as well as children with medical complexity. And then we're going to move into some of the challenges that are faced overall by both children, families, and their hospitals and their providers. And then we'll pass it over to Dawn after I'm going through the first like 20 minutes or so, hopefully shorter for your sake, and then get to Dawn, who really has some amazing insight as a family expert in this area. So if you go to the next slide, please. The first, as promised, we're going to open up with some definitions, and I apologize if you hear these ad nauseum for some of the folks who are attending. But children and youth with special healthcare needs are any children with chronic conditions that require services beyond children generally. Estimates really range from this says 13 to 18%. It has been higher in recent years. Frankly, it depends on the database that you use and the definition, but I would say pretty comfortably that they're about somewhere between like 1/5 of the population and even as high as 1/3 of the population in some estimates that you'll see later in Dr. Stade's slides. He quotes a little higher than this, but not like any of them are incorrect. It's just sometimes it's hard to define and nail down on a population health level. But I would think of them as a large part of the population that we need to be planning for, I guess is the point of that. Children with medical complexity are a subset of children and youth with special healthcare needs. That term's been around for probably 15 to 20 years. And if you flip to the next slide, I provide some more insight into children with medical complexity. So children with medical complexity are those with multiple significant chronic health problems. You saw on the previous slide, children with special healthcare needs, like a child who has ADHD or autism spectrum disorder alone would be considered a child or youth with special healthcare needs. A child with medical complexity often has multiple significant chronic health problems, usually involving multiple organ systems. They have significant functional limitations, and it's also accompanied by high healthcare needs or utilization. They often require, but it's not strict part for the definition, the use of medical technology. This again estimate also has been a moving target in a sense that original estimates probably 20 years ago or so, and a lot of databases say it's about 1% of the population. Many of us know who are in this field that it most likely is larger than that, especially as our health technologies and resuscitation efforts have advanced. Children are gratefully surviving longer, notably those who are resuscitated out of the NICU. So even though they only are a small percentage of the population, it is well understood that it's 1/3 of all medical spending in the pediatric population. If you flip to the next slide. So this is a little bit about my journey, just very quickly, and I realize now that this is a little in self-interest that I provide two articles that I've written, but I will say that the one at the top was one that I wrote as a fellow that I was working in the emergency department, and I had already recognized during residency, having done some research with children and youth with special healthcare needs, more focused on health policy, that I recognize that the care that we are providing children with youth with special healthcare needs in the emergency department, and specifically children with medical complexity, is less than ideal. And so what I proposed from that encounter with a specific patient, and this does go over a case about a child who was seen at a general emergency department, transferred to our hospital, had lost home care for the night. Parents couldn't take care of him and ended up being admitted to the ICU, most likely unnecessarily, when he potentially could have been home due to sort of a lack of advanced planning for a very expected event. It was a child who often had breakthrough seizures and had presented with seizures. Regardless of that, I just realized that maybe we needed to do things better. So it set me off on a sort of path in which to research and work with families, including the one that is actually featured on the bottom, to try and improve emergency care planning and disaster planning for kids with medical complexity. If you have not seen it, this was recently released. You can see it October 2nd, 2025, and it is what's called a family partnership piece, and that is Nora, who I received permission from her parents to include her, who I saw when she was very, very young in the emergency department. And it details a story about how some advanced emergency care planning prevented some pretty serious health interventions with her, including she was being intubated quite often at an outside hospital that she presented to because she has an underlying seizure disorder. And after we made an emergency care plan coordinated with that emergency department in Boston Children's, for an epileptologist, I was happy to report she has not been intubated a single time since. She has not been transferred to our ICU, and what that involved was some hard work, but at the same time, much, much better health outcomes with Nora. And so it's an interesting story to read, and it just illustrates the kind of things that we're trying to achieve by doing presentations like this, as well as on a population health level. If you could flip to the next slide. So challenges for families and providers. These are in those articles that were written before, because we did some qualitative interviews at one point with families as well as with emergency medicine providers. And the challenges range from transportation, housing, health resource availability, financial challenges, communications. I'm sorry to report that there is data that suggests that a lot of parents of children with medical complexity are solo parenting, as compared even to the general population. For providers, often taking care of children with medical complexity takes more time, expertise, and training as some of the big ones. And all of these issues that I just listed off with both families and providers and the communication between what could be coined the health neighborhood for kids with medical complexity, they all sort of coalesce and come together, and not in a good way. It really provides a lot of challenging experiences that somebody like Dawn and even some folks that are attending today could probably better detail than I could as personal experience. But I will say, as a provider, I've certainly witnessed this firsthand in the pediatric emergency department. If you could flip to the next slide. Taking that one step further, not only do we know that there are challenges in the emergency care of children with medical complexity and challenges during for disaster preparedness, but we also know that when children do come to the emergency room, that often those emergency rooms are not ready to care for them. And this is highlighted best by some of this pediatric readiness data that has been coming out for a long time, with a lot of the leaders in the PPN, frankly, have been leading a lot of this work, as well as extending beyond that. But I think what's estimated here, and I think really the important line that is shown here, is an estimated 2,143 pediatric lives may be saved each year through universal high ED pediatric readiness. This is not focused on children and youth with special healthcare needs, but I would say that it's even more important for children with youth and special healthcare needs and children with medical complexity that our EDs are ready to take care of them at all times. And that was kind of what was highlighted in that Nora story that I had before, is that making that ED pediatric ready really resulted in better health outcomes. I can't say confidently that it saved a life, but I can certainly say that it decreased morbidity in that particular young girl's case. If you could flip to the next one. So with disaster preparedness, sadly, disasters are expected to increase. That children and youth with special healthcare needs have unique and heterogeneous medical and social needs. There are significant challenges with preparedness that I just outlined and many of you are aware of. And also it's difficult to study this rigorously. So who is like the experts in this in terms of research? You can't really do a randomized control trial for disaster preparedness. It just doesn't work that way. And so it makes it really, really challenging. What we do here and what is really powerful in driving this work forward is an example that I have here on the right. And this is an article we passed around in our group, but also as something that I reference often when I think about why the importance of doing this work. And this mother, Beth Connor, who I've never personally met, wrote in here, and I pulled out a line out of this. My 6-year-old disabled son is up to 4 times more likely to die or be critically injured during a natural disaster than his non-disabled peers. This tells a harrowing story of providing rescue breaths over hours and hours after the hurricane. And if anything else could compel you of why it's important to adequately prepare for this population in terms of disaster preparedness, this story certainly would do that if you have not come across it. If you could flip to the next slide. I'm going to keep going on, and I again apologize for that it's me again talking about hospital disaster preparedness. This is not my area. It is certainly Dr. Stade's area, but I will say that from interacting with him and the group, I've learned quite a bit about this, and I'm doing some of this work in the state of Vermont, where I'm from. So Tim urges us to stick to the basics. So complete the Emergency Medical Services for Children Pediatric Readiness Program evaluation, and have basic plans and protocols for all pediatric patients in your hospital. So that includes children and youth with special health care needs. As I said before, they are a large portion of the general pediatric population. Ensure appropriate medical supplies. As an example, Nora, who I talked about before and wrote the story about, had tracheal stenosis after being in the NICU for a long time, and her local hospital actually at first didn't even have the tube size that she would require if needed to be intubated, and that required some coordination between us as it's hard when you're in a rural ED outside presenting to ensure they have the appropriate pediatric medical supplies, but it's probably up to many of us that are on the call today to be liaisoning with these with emergency rooms and other disaster preparedness sort of organizations to ensure that this is the case. So daily needs of pediatric patients need to be ensured: diapers, bottles, age-appropriate clothing. I think many of us know that. You go on the next one, sorry. Plan ahead. Pediatric emergency care coordinators make sure pediatrics and children and youth with special health care needs are included in all disaster policies, especially in community hospitals. That sort of reflects on the story that I was just saying. We have found, or I wouldn't say we, as I'm not directly involved in that work, but Tim has been, that many hospital disaster preparedness plans do not include children at all as a baseline. So not only going as far as being prepared for disasters to adequately treat children, but also children with special health care needs and kids with medical complexity certainly are not included if the entire population of children are not included. And hopefully I demonstrated the importance of doing so in preparing for all children in some of those previous slides. Of the hospitals that include pediatrics in the disaster preparedness policy, most do not address children with special health care needs. So we're just whittling down to less and less where children with special health care needs are adequately addressed in disaster planning. So again, it's up to many of us as advocates for children to ensure that we do a little better across the board. Next slide, please. Emergency information forms are something that was released in a joint statement by the American Academy of Pediatrics and American College of Emergency Physicians, probably, I think, and somebody could correct me if I'm wrong, dating back to 2007. They've been around for quite a while. Difficulties and transitions to EHRs and such have limited sort of their utility, but it is a really great template if you pull up the policy statement. And we are starting to do some work of integrating those into either larger databases that are statewide or in like hospitals EHRs, but it is something certainly that even as a parent of a child that you could download and perhaps work with your providers to fill out, and as a provider, ensure that children and youth with special healthcare needs have access to this, as well as some expertise in potentially collaborating and partnering with families to fill out. The STARS program is Tim's, certainly, or Tim or Dr. Stade's baby at Cardinal Glennon. It's a really amazing program that, frankly, you can Google and very quickly kind of learn what it is. But it's a registry for children with medical complexity in the St. Louis area. Many kids that are taken care of in that area, and it's a very advanced, far advanced beyond many programs that I know. Whereas even in the pre-hospital space, that the pre-hospital providers are receiving information that is critical for that particular child as they are en route to the house after an emergency medical services call, and that is flows right into the emergency department, where this pre-planning is already done for children and youth with children with medical complexity, specifically in this case. It's a really amazing program that Dr. Stade and his colleagues are attempting to spread more widely. And I think that sounds like the right thing to do from some of the outcome data that they've presented. And then get to know which children may come to your hospital and their specific medical needs. I think that might be the first step in all of this. I often hear from pre-hospital providers in Vermont, for example, that they don't know that a child was discharged from Boston Children's, as our local large tertiary care children's hospital, that a child with a heart defect was then discharged to their rural town that they are being asked to respond to. They're not actually aware that they're there. So awareness, I think, is one of the first steps in terms of working with pre-hospital as well as disaster planning. So if you go to the next slide, please. This is sort of getting to that. Work with local EMS and schools. They sometimes have lists of children with medical complexity in your area. Extraordinarily important for disaster preparedness and emergency preparedness. Prepare for technology-dependent children in your area. I know this was a challenge during some flooding in Vermont specifically, and you've already heard this story, or at least I talked about the story of a mother and family providing rescue breaths for several hours after flooding is really, really telling and important to adequately prepare and have awareness in the community that you're in, specifically for disasters. And then having transfer agreements or plans with local children's hospitals is also important. You can flip to the next one, please. And thank you, Christy. I saw in the chat that you're going through here and said it's not in the St. Louis region. It's already spread beyond it. So thank you for weighing in on the STARS program. So still stick to the basics. Need the same as all children. So the basic things also need to be planned for to then bolster services also for children with special healthcare needs. Proper disaster triage, patient tagging and tracking, decontamination, medical treatment, reunification plans, and safe places for unaccompanied children. Tim, when I was speaking to him before in preparation for this, urged us to start with the basics, notably as many hospitals and other organizations, again, are not even considering children in their plan at all. And this is starting with the basics is really super important for all children. If you go to the next one. Planning drills with local government agencies like a local healthcare coalition, state hospital associations, the state EMSC programs, if available, and then children's hospital in your region, as Tim notes, if they're available. Drills, hopefully they would welcome this type of interaction, and if there's any facilitation that we could potentially help do on the national level, I'm sure we'd be more than happy to try to do that, as oftentimes we have folks who are well connected across the PPN. If you go to the next slide. And don't forget mental health. Assessment tools like CyStart, if I'm pronouncing that correctly. Tim was giving me the rundown on this beforehand and I know that I know that Bridget also is aware of this, but help identify children who are acutely in need of mental health services. Addressing agitation is also key, and PPN Resource Central has multiple resources for this. I learned SciStart. I learned that it's actually based on the event and not based on like emotions, and can help predict who's going to have issues with PTSD. So many of you here know that in pediatrics, we're all about prevention and try to address things before they happen or before or up front in terms of children. And this SciStart, it seems like a wonderful resource in which to use to do that and help us predict who needs resources, notably after a natural disaster, especially as we know that mental health is I will just probably say not as addressed as widely as it should be for children in natural disasters. All right, I think we flip to the next one. All right, I'm going to take a deep breath and go on mute. But Don, you are up, and I'm so happy for that. And I welcome any questions at the end. And thank you guys for the chat. I'll peel through it while I'm listening to Don. But thank you so much for listening, and I look forward to some discussion at the end.
Thank you, Dr. Platini. Appreciate all of the information and kind of that level setting from the hospital system side of kind of our continued gaps as it relates to planning for not just children, but children and youth with special healthcare needs and those with medical complexity. As mentioned, I come at this first and foremost as a mom. My daughter is now 20, so I have navigated this for a really long time, and have had, a lot of challenges, just managing like our everyday disasters, if you will. And then to think about how do I have to navigate that when it's, not a sunny day for the rest of the world also, right? And we already have to deal with systems that are very fragmented at times, and also really strained already in current everyday aspects. And then when events happen that put additional strain on our systems, it makes it really even more difficult for everybody, but especially for families like mine that already have individuals that require a lot of support and have extra needs. So I'm going to share kind of just a little bit about some of my experiences over the years that stick with me when I think about disaster preparedness. So we can go to the next slide, if you will. So I don't have a lot of text, but I'm just going to kind of share a little bit vulnerable of my daughter and just kind of more story time of just some of the things that I think about. So this is my daughter, Taryn. And as Dr. Pulcini had mentioned, we don't have a lot of great data on exactly how many of our population are considered children and youth with special healthcare needs or children with medical complexity. And so it's when you can't quantify what's out there, it can make it difficult to understand how to assess your capabilities and the needs that these populations are going to have. But we know we're there. We know that they're out there. And even though we may be small population, we also know that we're very high utilizers, specifically children with medical complexity. And so we tend to frequent the hospitals and the clinics and the outpatient settings more often than most children. And so you are seeing and you are having a chance to come into contact with these families. And each and every time there's a contact, there's an opportunity to think about helping that family in their disaster planning, but also thinking about what is your plan and your response in your areas of focus should there be an event at your facility when these individuals are there, and how would you account for them? So when I think about outpatient clinics, a lot of our big children's hospitals have large ambulatory clinic, specialty clinics also. And then we have a lot of our tertiary and community clinics. But families like mine, I mean, often Taryn currently has 13 different providers, specialists. And so on a rotation of how often we have to check in, we're probably at a clinic at least once a month, if not sometimes twice a month. So the odds of something happening and us being at a clinic are far more increased than, children in general because we tend to be there. And so do most of our community. I often go to these appointments with my daughter and it's like social hour. We run into other families that we know. We see other kids like ours. And so I think just really being conscientious of that. And again, talking about how in those touch points are we able to work with families on helping them understand additional disaster preparedness and planning. I think about what Dr. Pulcini was talking about, the emergency care plans, right? And I love that we're working better on emergency information forms to be more integrated into health records and easily transferable and accessible, but we're not quite there yet. And one of the challenges that I think families face is we have multiple emergency information forms that we have to navigate and keep up to date. I just had my daughter's 90-day meeting with our state Division of Developmental Disabilities, which is where she receives her Medicaid waiver coverage through. And we went through her emergency information form there. And it made me realize that I have to update that every 90 days. And the information they ask for is different in context and wouldn't necessarily translate the same if you needed that to be used for like a hospital or an emergency room. I also have a different emergency information form for her education setting. Again, the information is collected in a very different context. And so I think as we continue this work, we also have to think about how are we gathering and sharing this information that's really beneficial for the individual and less burdensome on the families, because it is hard to stay up to date on all of these additional information forms that we have to fill out for every area of service that our children navigate. I also think we have to be thoughtful, like what Dr. Pulcini talked about, is children with medical complexity, thankfully, with a lot of the medical interventions over the years, are living longer. And they're able to thrive and have a life in a home setting with the medical equipment and all of the hospital at home supports, if you will. And a lot of our emergency preparedness planning within the emergency preparedness and emergency management realm doesn't take into account how to support in the preparation, response, and recovery for those types of families that have more of those hospital at home models. And so I think we have a lot of work and opportunity to bridge that clinical and the hospital and medical world into that emergency management and emergency preparedness space as well to help support these families during those. We can go to the next slide, please. So in addition to many clinical appointments, unfortunately, families like ours are kind of high utilizers for the emergency department or outpatient procedure and surgery clinics. And so we have to think about in those spaces, how are we, one, getting the appropriate information to care for these individuals? We're fortunate to have an emergency care plan within our medical chart. And that works really well if our emergency room visit is at our children's hospital. But if we have to seek care at an additional emergency room, like a general community ED or others, I'm unfortunately at the mercy of whether or not the team there is comfortable and gracious enough to want to utilize that emergency care plan. And so I think we have to help partner with our other hospitals with the pediatric preparedness work to help them recognize that these tools are beneficial and allow that comfort for them to be able to treat our individuals. And then on the flip side, I think about, we were recently in the ED in August, and while we were there, I was thinking about what if something happened and the hospital had to go into an emergency plan. how would that look for us? Like what would that look like for my daughter? How would we evacuate? Where would we go? How would we continue to address the emergent issue that we were faced with that brought us into the ED to begin with? And it was really kind of challenging because, to be honest, while the ED is helpful, there's aspects of the ED that are challenging for some of our families with medical complexity. For example, I have to pack all of my daughter's medications to take with us when we go to the ED because they aren't always able to get those meds when we're there for 8 to 10 hours while we're figuring out what's going on and whether or not we're going to admit or not. And so we come as prepared as we can, but knowing that we have to be so prepared for just a regular ED visit, I wonder how that would be affected should there be a disruption within the ED and providing the care for our population as well. Next slide, please. And then I think about when we're inpatient. So these are just some pictures of our inpatient stays. And they vary, right? Like over the years, we've had some, mild stays where we just needed some added support to get her healthy again and address some of, whether it's an infection or hydration or GI. But then we've had some pretty critical stays. We've had some like massive spinal fusion surgeries and ICU stays. We've had PMU stays, pediatric epilepsy monitoring unit stays. And then we've had really unexpected illnesses that took us down really challenging paths where, we were critical and intubated and septic for a long period of time. And I think about, should the hospital have to enact an emergency operation plan or an evacuation? What would that look like for us? What would that look like for my daughter and for me? I put the picture of myself with my daughter there in the bed because the reality is I don't leave the hospital. When she goes in, I go with her, and I never leave her bedside until she is discharged. So the families also have to be thought about, caregivers, parents, with these individuals during those plans. How are you going to account for them? And how can you utilize them as resource during those events? I also recently had an event where we had to go down. My daughter was in getting a CT under anesthesia. So obviously I was not in the room with her. I was downstairs with her, but I was in radiology waiting. And while I was sitting there, the fire alarm went off in the hospital in the main tower. And I just panicked and thought, what does that mean? If they evacuate, do they take her somewhere else and I have to go somewhere different? How do I make sure I get connected with her again? Is she going to be okay? She's under anesthesia in a CT. What does that look like? I think we also have to be cognizant that when you have children with medical complexity, especially epilepsy and other conditions, added stress exasperates medical conditions. So it's really easy for our population to decompensate during times of crisis. And how do we plan accordingly to make sure we're able to address those ongoing needs and not just what we know they're there for at the moment? I really think about what Dr. Pulcini shared about that mom saying that her child is 4 times more likely to die in a disaster. It weighs on me in the work that I do. I think families like mine, we have fought for years. We've done everything we can to keep our children alive and thriving as best as they can with as best quality of life as we possibly can. And it's really disheartening to think that a really bad day for the rest of the world could mean the ultimate bad day for us because we're just not prepared to meet the needs. And we have to rely on the system to support us during those times. We are probably the most resilient and prepared individuals you will find, but we can only be prepared to a point. And when things like that happen, we are at the mercy of needing our systems to come alongside and support our families and our children, even on those worst days. And so it's important for us to think about, how do we include them? Um, these families require a lot, but they matter. These families know how to navigate a lot, use them. Um, at the same time, we have to understand that these families navigate disasters each and every day. And so we have to ask the systems to step up a little bit more and to be part of that support during the disaster, and it not all fall on the families to have to navigate systems that are already hard, that would then be even harder. So thank you for letting me share. Next slide. And I think we're going to turn it over to Q&A and discussion. So,
Juan and Dr. Pulcini, just thank you so very much for sharing and this information. Hopefully it can help a couple people, help a couple hospitals and systems really consider children and youth with special health care needs and children with medical complexity. Taking those first steps can sometimes be the hardest. I'm curious to see if anybody on this call has any a plan or an annex to their plan that includes children and youth with special health care needs. I will, full disclosure, my previous hospital, we had one paragraph for our entire emergency operations plan, and all it said was special considerations for children and youth with special health care needs, and that was it. It didn't say what those considerations were, didn't list equipment, didn't list support services within the community. So I'm curious if anybody else on the call, on the call, in the meeting has anything in their plans or anything to share or ask our panelists. We are a quiet group on this Wednesday, October 15th.
I can jump in and just tell you guys some exciting news. Since you are joining here today, you're obviously interested in this topic, but I wanted to let this group know specifically that we are working with the American Academy of Pediatrics, as I sit on the Committee on Pediatric Emergency Medicine, to hopefully do a half-day programming at the AAP meeting, specifically on children and youth with special healthcare needs in terms of disaster preparedness and everyday emergencies, which would be an exciting collaboration. So I know many of you may have a lot of expertise in that, and that will be in San Diego, sunny San Diego, in 2026, so next October. But we're hoping to finalize those plans, and then further beyond that, hopefully what's going to spurn out of that is an official statement from the American Academy of Pediatrics, the Council on Children with Disasters, Council on Children and Youth with Disabilities, as well as the section on emergency medicine on this exact topic. So we're hoping to get some more tangible information out there. I will say a clinical report, I'm not exaggerating, takes 4 or 5 years from start to finish, and we haven't started yet, so if that gives you any indication. But at the same time, the Pediatric Pandemic Network has some amazing resources, as well as dissemination of other resources on our website that can help right now with this population, that I would encourage you to sort of search through and get through. Especially the Be Ready toolkit seems to be one of the ones that's particularly helpful. I see Chrissy has a hand up.
Yes, first of all, thank you all for doing this presentation and this fireside chat. One thing that's been really encouraging in doing this work with the PPN is all of the conversations that we keep having, especially with our EMS partners and EMSC. I do know that there's several people out there that as they work with EMS and EMSC, that they keep asking the questions, what is the plan? Not just for pediatrics, but for children and youth and special healthcare needs in their plans. So the word is getting out. I think PPN's doing a great job in advocating for this group. and not just for all of pediatrics. So just keep talking about it, keep bringing up the conversation anytime you get to. I know these conversations are being had at healthcare coalitions, in um, state emergency management group meetings, etc. So just keep asking for keep asking the question, keep including them, and we can all move forward with this if we can all advocate for what is right for this group.
Thank you so much, Christy. And I'm gonna throw this question in the chat to Dr. Pulcini, and Dawn, perhaps if you have information, but during Dr. Stade's slides, technology-dependent children were mentioned. Do you know, or anybody else on this call, if tech is ready for children who might need it during a hospital visit or a disaster? Is that, Julie, is that tech at the hospital to help these kiddos?
Yes, I was wondering if anybody on the call and anybody, speakers or participants, if anybody had experience with this and what kind of tech have you used? Is it ready? Is it thought that the parents would bring it? Or, you know, what if it was a bus crash and you had children with special health care needs that came to your hospital? Is there tech ready for these children? Has anybody given that any thought?
That's a difficult question. That goes back probably the pandemic when they increased the number of ventilators. For example, I think that would probably be the one that is important to discuss, is the children who are ventilator dependent in terms of technologies, as that would obviously be the most imperative to address up front, because it's life or death at that point. There is a limited number of ventilators in hospitals. There are a lot, but could they accommodate all a group of children requiring them, especially when you're thinking about that there might be healthy children that also require ventilators because they need to be intubated in the setting of a natural disaster? That's actually a really good question, to be honest with you, I haven't considered, and it's probably somewhat of a, I'm sure there's some wonderful mathematician out there that could estimate the number needed in the setting of an expected natural disaster at this juncture, but it actually is an interesting question that I don't know the answer to. Like, what would be the number needed to consider the number needed to adequately serve the population? Also, probably depends on the population. I think last time I checked, in the state of Vermont, there's not that many people in Vermont, and so I think there's under 200 kids who are ventilator dependent in the entire state of Vermont. Whereas where I was in the Children's Hospital of Philadelphia and the surrounding area, there was probably 200 within a 5-mile radius or so of the Children's Hospital of Philadelphia. So I'm sure it's completely institution dependent as well as population dependent on who's around you. Maybe Dawn has a better answer because she has her hand up and she could save me on this one.
Not necessarily a better answer, Dr. Pulcini, but just something to add to think about, because I think that is a really good question. And I'll just share a couple thoughts. So in my own experience, when, you know, we've gone to the hospital, oftentimes the hospital wants us to use their equipment when we're inpatient, right? So, you know, for us, we don't have a ventilator, but my daughter does require some respiratory support, like CPT vest and cough assist and nebulizer, inhaler, and then a feeding pump. So oftentimes they like to use theirs. And so I got in the habit of, I stopped taking like our feeding pump with us because it's just added stuff for me to have to carry and manage. But now it has me thinking, like, should we always try to have our own equipment with us? Because if it's not just our own personal disaster day, but it's also like a disaster for everybody else, is that going to be an issue? And I think those are important things as a hospital and an institution to think about. I also have the privilege of working in Arizona on revising and updating our statewide crisis standards of care. And I'm having the opportunity to ensure that we have considerations for this population built into those crisis standards of care, because typically they haven't been. And I think one of the hard things that came out of the pandemic was because of a lack of resources and traditional ways of allocating very, scarce resources, there's a version of deciding on future quality or potential survivability, if you will. In Arizona, our disability community really rose up during the pandemic to say, you can't decide that our lives are less quality or less survivable because of a disability, because that's not always the case. And so our state passed a state statute that said, in these events, you cannot use disability as a consideration for scarce resources. But what does that look like? How do you assess and evaluate without taking into account somebody's already like baseline condition that might put them at a lower? And so I have the opportunity to weigh in on what that looks like for families like ours who, if you're using assessment tools, my daughter would fail on a great day already. So how do we take into account these individuals' baselines, and how do we help our systems and our hospital systems navigate those challenging events? And so I think there's opportunity. Now, granted, my work is only in the state of Arizona, and everybody does things differently. But I think as we think about disaster plans, it's not just decon, it's not just evacuation, it's not just reunification. We have to think about what happens when we get into contingency standards of care. What happens if we get into crisis standards of care? How are you thinking about the needs of this population? What are your resource capabilities, and how do we work with the families and plan alongside to ensure that we can utilize the resources that some of us have in the home to be able to carry us through that? So I'll just add those thoughts.
I just wanted to add, Dawn, that is huge work that you're doing, and I think that's amazing. That's something that we have been trying. I'm at IU, for those that I haven't met yet, Indiana University at Riley Children's Hospital, peds emergency medicine there, but also the medical director for emergency preparedness. And some of the things we're trying to do are include children and youth with special health care needs in our surge exercises. So putting them in as example patients, and then also in our mass casualty incident plans and triage plans. And I think I'll talk about that a little bit more at the next fireside. But a couple other things I wanted to add, just with the question that was asked. What we have done here in Indiana is we're working with our electric companies. And I know, Dawn, we've had these conversations before also. And a lot of the electric companies will have a list of patients that they won't officially say they will prioritize, but they will have that information available to them so that if there is an outage, they can basically address those needs, those families first, ideally, if they can. And so really, but a lot of people don't know that these exist. And so making sure that a lot of the work I do is trying to educate our pediatricians. That's sort of the focus area that I have. But there's this needs to get out to really a huge number of people involved in emergency preparedness from all levels, from, the families to EMS to the providers. But identifying if that's available in your state, and if that's something that the families are on already or need to get on. And then also, I would say, Dawn, you're kind of a pro at this, and I think you've done amazing work in educating other families. But a lot of these families, when they first, we'll see them in the emergency department when they kind of first get that diagnosis, or they are discharged and then come back and don't have all the knowledge. And I think that's a huge gap that we have in getting the information to them that they need, and getting the support that they need, and all those things that you've learned along the way. We need to be better at really giving that information to them and getting them comfortable and aware and all the things that they need before, they learn by, troubleshooting, basically.
Thank you so much. This was incredibly incredibly helpful and powerful um, webinar and presentations. Final words from our speakers. How about we look forward to seeing you next month?
Yeah, a final word. Obviously, my passion in this is recognizing that the areas we have a lot of work to do in. And I know that a lot of what I say is constantly highlighting the gaps and the needs. But what I want to say is that I feel so optimistic and so privileged to be able to work in this space because I see the commitment and the passion of all of you who are here today and all of my colleagues on the task force and other areas that I work in PPN. And so while I probably sound like a broken record of all the continued needs, please know that I say that because I know that this group has the will and the power and the energy to keep making these things better. So just thank you. Like, I feel so honored and privileged, and I appreciate the chance to get to work with so many of you very closely on a multitude of areas around this. And I just wanted to say that. So not to always be the Debbie Downer, but thank you.
You're wonderful, Dawn. Dr. Pulcini, any parting words?
I'm not going after that. That sounds great.
Awesome. As we alluded to, for this series about planning and preparedness for children and youth with special healthcare needs and children with medical complexity, our second session is Wednesday, November 19th, same time, I'm totally biased. So 9 a.m. Pacific, noon Eastern, or 11 o'clock Central for you Central people. And it's about disaster planning. And Dr. Lafort is going to be one of our speakers. We've got three different perspectives. Again, we're going to have family perspective and then emergency department planning perspective, and then an EMS person. Nick Salzman is with the STARS program out of Cardinal Glennon Hospital. Laura put the registration information for this session in the chat. There's also, Dr. Bolcini mentioned mental health, and there's another fireside chat just the day before about the management of pediatric PTSD. And so that is going to be, I can't do the math on this one in my head, at 11 o'clock Pacific, 2 Eastern. And registration again is in the chat for that session. So in the last 2 minutes, we've got some continuing education available for those of you who are seeking it to get credit. Text the code to the number that you see on the screen, or go to the website and enter the session code. You have to be logged into your PPNCE portal account to get credit for this. And with that, with 1 minute remaining, we have a QR code for session evaluation. And I want to take the last 10 seconds and then I'll open it up for anyone else who wants to speak, just to highlight the importance of these chats and the sharing of ideas and resource that happens during the chat. So absolutely grateful for each and every one of you for choosing to attend. Thank you.